low-level BACE inhibition, because eventually we need an oral disease-modifying therapy for Alzheimer's disease. So we're going to have a panel discussion and a Q&A session after the talk, so I ask the attendees to save their questions until then. We have microphones set up here in the room for those attending in person, and Reese and I will be monitoring for online questions from the virtual audience. So our first speaker will be Elise Watkins from Northwestern University, who will be presenting the case for low-dose BACE inhibition.
Good morning, everyone. My name is Elise Watkins, as Bob said, and today I'm going to try to convince you to bring back BACE inhibitors into clinical trials. As you know, BACE is involved in amyloid precursor protein cleavage, so it cleaves just proximal to the membrane, and when followed by gamma secretase, this yields the A-beta peptides, which oligomerize and forms plaques. It's been long known that APP transgenic mice, when crossed to BACE knockout mice, fail to develop plaques. Given this integral role of BACE in the buildup of amyloid plaques, many pharmaceutical companies developed small molecule BACE inhibitors in order to prevent this plaque pathology. So in these late-stage clinical trials, these BACE inhibitors were able to cross the blood-brain barrier. They demonstrated a reduction in amyloid beta 42 in the CSF, as well as even a reduction in amyloid by amyloid PET scans. However, it was noted that there was an early, non-progressive cognitive decline. So you can see as early as 13 weeks that there was a slight reduction in facets of cognition such as memory. It's thought that this impairment is potentially due to the inhibition of cleavage of other BACE substrates. So BACE not only cleaves APP, it also cleaves a number of other substrates that are involved in, for example, axon guidance and synaptogenesis. However, it's very important to note that in these clinical trials, BACE was inhibited by at least 50% and often closer to 70 to 90%. Additionally, especially as seen here in the adabetastat trial, it was demonstrated that although there's cognitive worsening after the study begins, once the drug is withdrawn, so in the bottom panel, in panel C, this is about 3.5 months, median of 3.5 months after the drug was withdrawn, the cognitive worsening goes back to baseline levels. So these clinical trials inhibited BACE to a great extent, so we need to think about inhibiting less than what the 50% was tested. And additionally, it suggests that if there is cognitive decline, this would be reversible if the drug was withdrawn. So the question that we have in the field is, what is the right level of BACE inhibition that slows accumulation of amyloid while avoiding cognitive worsening? So from this, we can learn from genetic literature. About 10 years ago, it was demonstrated that there's this A673-T mutation that's close to the BACE cleavage site that actually protects from AD. So here you can see where it's located. Unlike the Swedish mutation, which enhances BACE cleavage of APP, the A673-T Icelandic mutation actually reduces BACE cleavage of APP by about 30%. In this Finnish cohort of men, it was noted that individuals that had this A673-T mutation had about a 30% reduction of A-beta 42 in their plasma. So potentially 30% is about the dose that we need to be aiming for. So to get to this question, I'm conducting a long-term BACE inhibition dosing study beginning early in amyloid pathology to shed light on the sweet spot of inhibition. So the reason we're doing early in pathology in this preclinical model is to model something like either a primary prevention study or a study in which amyloid is cleared by anti-amyloid immunotherapy, and then we come back with a BACE inhibitor. And so here we have the PDAPP mouse, which has the Indiana mutation. So this lacks any mutation close to the BACE cleavage site. Then at about 8 months, which is very early in pathology, we start dosing with BACE inhibitor in the chow. So this is a Merck BACE inhibitor at different doses. We inject methoxy-XO4 as a timestamp to note what the plaques look like at the time of treatment initiation. And then at 14 months, we conduct some behavioral studies, such as novel object and novel location recognition, rotarod and water maze. In addition, we look at various markers, such as neurodegeneration and amyloid burden. So you can see here at baseline that you have some plaque, but not a substantial load. At 14 months of treatment, the control chow, you can see that there's a hefty amount of A-beta marked by A-beta 42 on the cortex, and there's a dose-dependent reduction of A-beta. And this is quantified here, where you can see a dose-dependent reduction of A-beta, as one would expect, with the lowest dose of 11 mg per kg per day having about a 40% reduction in A-beta. Additionally, this is seen that there's a reduction in soluble A beta in the cortex. As well, we see that there's a reduction in methoxy. So remember, methoxy was the timestamp here, and we can see that the reduction in methoxy suggests that not only are we preventing the buildup of new plaques, we might actually be clearing some existing plaques that were there at the study initiation. So the aim is to correlate BACE substrates and neuropathological findings with levels of worsening. And so Stefan is going to talk later about what he's done with the human studies, and so we're trying to do something similar in mouse studies to correlate some of these substrates with some of the behavioral parameters and cognitive worsening. So with that, I would like to thank everyone, especially Bob, and welcome the next speaker.
So our next speaker is Jochen Herms from the DZNE. Novel BACE1 selective inhibitor does not affect dendritic spine plasticity.
Yeah, I would like to talk about BACE and synaptic plasticity. I mean, if you stain for BACE1 in the mouse brain, you see this brown staining, which really shows typically synaptic staining. In BACE knockouts, you have no staining. So BACE is a synaptic protein, so if you interfere with BACE function, you may affect synapses. I mean, my lab has a long history on looking into spines by using in vivo to photon imaging. So you implant a glass window into the skull. This allows to image repetitively into the mouse brain. With this, you are able to find the same dendrites over time, and you can do chronic experiments on the effect of compounds on synaptic plasticity. And this one dendrite is shown here, this over 43 days. You see there's certain change in the spine stability. Some spines come and some go. And this is the structural basis of learning memory, what is believed. So we looked at the effect of BACE inhibition on this spine plasticity. So this is the study design. We implant the glass window. We wait for 3 weeks of recovery. And then we image the same dendrites over time and look for spine plasticity. And we gave a BACE inhibitor for over 3 weeks and look what happens to the spine plasticity throughout this treatment. We started with a compound MK8931, varibecestat, which also went into clinic. And what we observed here is that with the application of the BACE inhibitor to the mouse, the spine density slightly decreases, about 5% over time. And this is reversible. And this effect is mainly due to the effect on the spine gaining. So the formation of new spines is inhibited up to 50% by this BACE inhibitor. This is not only true for this BACE inhibitor. We see this with various BACE inhibitors, also from sharing and so. And we made similar observation also in other brain regions. For especially in hippocampus, the effect is even stronger than the cortex. So how does BACE inhibition alter synaptic plasticity? If you look at the proteins that are cleaved by BACE, on the very top, you see protein 6, CSR6. And CSR6 is even only cleaved by BACE. And it's a synaptic protein. BACE cleavage leads to release of this extracellular domain, this soluble protein fragment. And if you go for BACE inhibition, you see that the soluble protein is not detectable anymore. So in order to test if really CSR6 cleavage is critical for spine plasticity, we went into BACE knockout mice and crossed it with the GFPM mice, which labels the spines, and asked a question whether if CSR6 is lacking, if spine loss still occurs. So we crossed this CSR6 with the GFP mouse. We looked at the spines over time, gave the BACE inhibitor. And what we observed is that BACE inhibition, the gray time, did not affect spine density. In CSR6, the spine density is a little bit lower than the wild type, but the BACE inhibitor has no effect on spine density, which implicates that spine loss following BACE inhibition may be due to the reduced soluble CSR6 levels at the synapse. And the spine loss may be responsible for these well-known cognitive worsening and gray matter atrophy in the clinical trials. And varibecestat, the study, this compound we tested, did show these side effects in humans. And if you look at the other compounds, you see not all do this cognitive worsening. There's ellenbecestat. Actually, we did not show this cognitive worsening, and Shianogi asked the question what is the reason why the ellenbecestat does not do cognitive worsening. And they came to the point that the BACE1, BACE2 selectivity may play a role, because ellenbecestat is much more BACE1 selective. This is here the quantification. So Varian-Beckerstat is not selective, Allen-Beckerstat is selective. So they developed two other compounds which were highly selective for BACE1. And they asked us to look whether those compounds affect spine plasticity. So and this is the final data slide I would like to show you. So on the left, you see the spine density, and then the time after the start of BACE inhibition. And as you can see, compared to vehicle, Allen-Beckerstat has no effect on spine plasticity, and Shionogi 2 has also no effect, but Shionogi 1, to our surprise, reduces spine density similar as the other compounds. So what is the reason for that? If you look for the soluble C6 with compound 1, which causes the spine loss, you see that the soluble C6 level is dropped up to 17%, whereas the other compounds affect the soluble level only to 27 or 39%. So the amount of reduction may play a role for the synaptic side effects. So in summary, BACE inhibition reduces clearly dendritic spine density. The effect is most likely due to the reduced cleavage production of the soluble fraction of the C3 protein 6 at the synapse. And soluble C6 levels below 20%, we cannot accurately say which percentage is, but we see it with 70% spines, the spine plasticity is affected. So we guess above 25% is safe. So at 20% of vehicular basal levels may lead to reduced spine plasticity. And the measurements of soluble C6 levels in body fluids like CSF may allow a personalized adjustment of dosage to avoid synaptic and cognitive side effects of BACE inhibitors. So I would like to thank especially Katrin Patsch, who did the study with the compound from Chianuri, and Severin Filzer and Tanja Blume for the other studies of the other BACE inhibitors we have studied. And I would like to thank Chianuri for their support throughout the study. Thank you very much for your attention.
Our next speaker is Richang Yan from the University of Connecticut. Inhibition of BACE1 in glial cells for enhancing clearance of amyloid plaques.
Thanks for organizing this session. And a few years ago, we published a study on the conditional BACE knockout mice. By deleting BACE at a different stage, you can see without deletion, the amyloid plaque will continuing growing and accumulated. With the BACE deletion, the pre-existing plaque can be removed if BACE will be deleted more and more. So we asked the question, why is that? So now we have evidence. If we delete the BACE specifically in microglia, and we using the 5X mouse model, you can see in two different age groups, amyloid plaque are reduced, and the quantification confirmed that. So we think deletion of microglia BACE1 actually changed the microglia signature. So instead of 3 signatures we normally know, now actually we find out the microglia actually have a homeostatic and transition state, DAM1 and DAM2. BACE deletion expanded significantly of those transition signature. So we also analyzed the human microglia signature by looking at data published by Polo's group in Nature Neuroscience and Mark Corona's group in Nature Medicine. In both data sets, you can see BACE actually levels quite low in the transition state. And when BACE levels low, those genes involved in the transition state actually really elevated, which is shown in the boxed area. And now we think microglia in the 5X model has 4 different signatures, moving from homeostatic to transition and DAM1, DAM2. BACE inhibition pretty much enhanced the transition state. Functionally, you can see BACE deletion actually really enhanced the microglia in close contact with amyloid plaque, both in male and female cases. You can see the female microglia are a lot more activated. Male is more activated compared to the female, but in both cases, they actually reduce the plaque. the phagocytic function really enhanced. Mechanistically, we feel, toll receptor is likely the target. So BACE deletion will enhance the toll receptor signaling function, induce the gene involved in these signature. We also deleted the BACE1 in astrocyte. By deletion 5X model astrocytic BACE1, you can see the plaque also reduced in the early stage and not too obvious in the later stage. So we think in a microglia effect may be more obvious. But in the astrocyte, BACE will cleave insulin beta subunit. Without the BACE1, the insulin signaling pathway really enhanced, will induce the gene expression such as clustering, ApoE, CXCL14, and the published data already shown enhanced clustering and ApoE expression will really enhance the A-beta clearance. So in summary, we showed deletion of BACE in the glial cell really enhanced the A-beta clearance, and we don't see any long-term potentiation reduction. So that will be a good strategy for inhibitor BACE for AD treatment as well. So finally, I want to thank those who contributed to the study, mainly from Neeraj Singh and John Doe and Mark Benoit. Thank you for your attention.
Our next speaker is Stefan Lichtenthaler from the DZ&E. Human CSF pharmacoproteomics establishes in vivo relevant BACE1 substrates as pharmacodynamic biomarkers for chronic BACE inhibition in clinical trials.
Thank you very much, Bob. This is the shorter title. This is my disclosure. You've heard in the preceding talks that several BACE1 targeted inhibitors have made it into advanced clinical trials, but 5 out of those 6 induced mild cognitive worsening as a side effect that is unacceptable and that needs to be prevented if we want to bring the BACE inhibitors back into the clinical trials. The molecular cause that underlies this cognitive worsening is assumed to be mechanism-based and, as we heard, to result from a too strong degree of inhibition of BACE1. Because we do know that BACE1 has a number of additional substrates besides APP, and their function may be interfered with if BACE cleavage is too strongly inhibited. Now, we took advantage of the fact that if the membrane protein substrates of BACE1 are cleaved, that their extracellular domain is released as a soluble protein from the neurons in the extracellular space and may potentially be found in the human cerebrospinal fluid. And that's why we turn to proteomics to help to make the use of BACE inhibitors safer. And we asked 4 key questions. Which of those BACE1 substrates and their cleavage products can indeed be detected in the human CSF? Which of them would respond with changes in their levels in response to a BACE inhibition? And do these CSF proteome changes globally correlate with the degree of cognitive worsening? And finally, do we find evidence that may suggest that a dose lowering may be a way forward in order to prevent the cognitive worsening? Stefan Müller and Peter Gisberts in the lab addressed these questions, and they used samples, CSF samples from studies where we had 2 samples available for each participating individual. One pre-dosing sample taken just from before the dosing started, and one post-dosing sample just after the last dosing had happened. And then they set up the proteomics and analyzed in this way the samples from 3 clinical trials. Varebacestat is the only among the BACE inhibitors where the phase 3 studies have been completed to the point that for enough individuals in each dosing arm, both a pre- and a post-dosing sample was available. For atabacestat and umibacestat, we instead went back to phase 2 samples and again had different samples from different dosing groups available. The results of the proteomic study are displayed here in a volcano plot, where on the x-axis you see the fold changes of the protein cleavage products in the human CSF as a result of BACE inhibition. On the y-axis, you see the significance, and the higher up a protein is, the better is its significance value. So all the proteins shown here in blue are membrane proteins where the base cleavage product was significantly reduced as a consequence of BACE inhibition. This is shown here for one of the higher doses of umibacestat. Similar picture for veribacestat, again the high dose. You see the very same proteins showing up. Even the effect sizes on the x-axis, the quantitative changes, are pretty identical. Some proteins are even higher up simply because we had a larger N number and therefore a better significance value. And when we look at the high dose of atabasistat, then we again see exactly the same proteins with similar quantitative changes. There was just a single protein that was upregulated, that is shown here in red, MAG, or myelin-associated glycoprotein, that was consistently upregulated. Because it was upregulated, it obviously cannot be a BACE1 substrate, and at present we don't know whether it may also contribute to the cognitive worsening side effect. What we can conclude from this slide is that the BACE inhibitors, 3 different ones, induce qualitatively and quantitatively similar proteome changes in the human CSF proteome. Let's now have a look at the dose-dependent changes of the proteome. I'll show you this first for the soluble CSF6, the substrate that also Jochen Herms has alluded to, and afterwards I will show you the global changes for many of the proteins at the same time. We determined, based on the mass spectrometric measurements, the dose response curve for umibacestat. It looks very similar for veribacestat and for atabasistat. And to validate the proteomic findings, we also analyzed all of the umibacestat samples by Western blot. And you can see here the soluble CSF6 cleavage product in the human CSF, here in the pre and here in the post-dosing sample of somebody that was treated with a placebo. So there is obviously no change, just as we expected. Whereas for all 3 individuals that were treated with the inhibitor, the post-dosing sample showed much lower soluble CSF6 levels compared to the pre-dosing samples. We then determined a dose response curve based on the Western blot data, and this shows a very similar curve compared to the mass spectrometric data. Importantly, the dose-dependent reduction that we see for the soluble CSF6 correlate very nicely to the degree of reduction of the A-beta 40 in the very same individuals. So from this slide, we conclude that the reduction of CSF6 is validated with a different method, occurs dose-dependently, and correlates well with the reduction of the A-beta. Now, how about the many other BACE1 substrates that we had detected? This is shown in the overview here. In light green, you see the CSF6, which is this curve here, and that's exactly the same dose response curve that I've shown you on the previous slide. Now I've added in a number of other substrates and also the A-beta 40 and 42, and you can appreciate down here with those lines that at every dose, the reduction in the A-beta 40 is a little bit stronger than the one of the soluble CSF6. Now there are other 2 important take-home messages from this figure. First one is, while CSF6 and A-beta show a pretty strong reduction at this highest dose, some of the other substrates only show a partial reduction of their cleavage product in the human CSF. And the reason simply is that some proteins, CSF6, A-beta, are nearly exclusively generated by BACE1, whereas many of the other substrates are not only cleaved by BACE1, but also by other proteases, such as alpha-secretases. And therefore, if you block BACE1, you will obviously only block the cleavage that is dependent on BACE1, but not the remaining cleavage that depends on other proteases. The second important finding is that you can see that all those dose response curves reach a plateau very early on, not only at the high dose, but at the lower dose and even a slightly lower dose. And this is a very important observation when we now correlate these changes in the proteome to the cognitive worsening. And this is indicated here for the umibacestat with those 2 doses that were used in the phase 3 trial. I show both doses in red because these are the ones where the cognitive worsening was observed. And you may appreciate that even at the lower dose, there was already for most of those substrates a maximum or nearly maximal inhibition of their base-dependent cleavage. Similar picture for veribacestat. Even at the low dose, already maximum inhibition of all of those substrates. The situation was only a little different for the atabasistat, where at the lower dose, there was not yet a maximum inhibition. And if we now look at the doses that were used in the phase 3 trials, you can see that the 5 milligram group, which is now shown in blue, was the one that showed a trend, but not a significant one for the cognitive worsening. So what we see is that the degree of the cognitive worsening obviously depends on the dose and correlates nicely with the degree of inhibition of the substrates. And with that, I come to my summary. At present, we clearly are not yet fully sure which individual substrate or combinations thereof is causing the cognitive worsening. It may be the CSF6, potentially there is even a contribution of the A-beta or some of the other proteins, but what we can very clearly say is that the cognitive worsening occurs always at drug doses where the BACE1 substrate cleavage is nearly maximally or maximally inhibited. And this brings us to our conclusion and the proposal that we should use a dose lowering of less than 50% of BACE inhibition, which should allow enough substrate cleavage of all of those substrates to happen to prevent the cognitive worsening while maintaining therapeutic efficacy, at least in a preventive setting. And if we now talk about starting new inhibitor trials with the BACE inhibitors, then we should power the studies to the point that we get enough CSF samples from individuals so that we can also in the future look for potential effects or potentially even side effects and correlate them to the changes in the cleavage of these many different substrates. With this, I would like to thank in my lab in particular Stefan Müller and Peter Gisberts, and I would like to thank Matt Kennedy, Anna Graf, Ulf Neumann, and now Taka Horiguchi for a great collaboration. Thank you very much for your attention.
Terrific. And our next speaker will be Alberto Yeo, who will talk about neuropathologic changes in a patient who was treated with varibazestat. Thanks.
Good morning. Well, thank you for inviting me to this session. These are my disclosures, and the other disclosure is that I'm not a neuropathologist, I'm a neurologist, but I have been doing research on digital neuropathology for the last 10 years. The objectives of this study is to describe the clinical pathological data of a case treated with low doses of varibazestat and to compare the neuropathological findings with those from a group of sporadic untreated age-matched AD cases. The clinical data was a male patient with gradually progressive memory impairment at the age of 54. Past medical history was relevant for diabetes, high blood pressure, and celiac disease and a partial factor VII deficiency. Had no family history of dementia, had no mutations in APP or presenilin genes, and his ApoE genotype was 3-3. He had been diagnosed of mild AD, typical atypical syndrome, by CSF biomarkers, and he had been treated with rivastigmine. The patient had been enrolled in a clinical trial with a GSK3 inhibitor, tideclusib, for 10 months, receiving the active treatment. 8 months after the end of that trial, in a stage of mild AD dementia, CDR1, the patient was enrolled in a phase 3 trial of varibazestat, and he received oral varibazestat 12 milligrams per day for 24 months during the double-blind phase plus the extension phase. The total treatment period was 38 months, and after that he developed a progressive cognitive and functional impairment until death at the age of 63. So 53, that was 53 months after the first dose and 15 months after the last dose. So there was a wash-off period of 15 months till death. So the macroscopical examination showed remarkable atrophy in frontal and temporal areas. The weight was 1,300 grams. In microscopical examination showed high density of diffuse and primitive A-beta deposits, but few core plaques. This was one of the remarkable features, were the few core plaques in this case. There was no amyloid angiopathy. And there was also high load of tau-positive neurofibrillary pathology with abundant neurofield threads. Here you can see some examples. At the bottom you can see extensive neurofield threads and neurofibrillary tangle degeneration. And there were only few tau-positive neuritic dystrophies around plaques, as you can see here at the top. At the bottom, you can see some examples of plaques, from diffuse plaques, peroneuronal, and only few core plaques. Together, diagnosis was compatible with high AD neuropathological change. So we next did a quantitative analysis using our published methods. We basically selected the frontal and occipital regions for the study, and we scanned the full sections, and we stained it with different antibodies and they quantify using an in-house math lab algorithm. So we stained for NAP61, which was a gift from Virginia Lee, and this antibody detects oligomeric A-beta, but also a subset of high-order A-beta structures. We also stained for total A-beta, for tau, GFAP as a marker of astrocytes, ABA1 as a marker of microglia, and three synaptic markers, PSD95, synaptophysin, and SNAP25. So this is the list of cases included in the study. The 9 sporadic and treated cases were matched by age to the treated case, which is indicated here with an arrow. The quantitative analysis showed that the case treated with berivesostat was pretty much in the range of the other untreated cases. The only remarkable finding was that when we calculate the ratio of NAP61 to total A-beta, this case had the lowest signal in the occipital cortex, but not in the frontal cortex. The other remarkable finding was the plaques. The size of plaques in this case, in the treated case, was small. Compared to the other untreated cases. And because we know that APOE genotype can influence the type and the size of plaques, we compared to the group of APOE 3/3 in the study, and we found similar results. We also quantify a GFAP and IBA1, and we found no differences in the immunoreactivity in the treated case compared to the group of untreated cases. And because we know that there was cognitive impairment and also synaptic is at the center, as we have heard, at the center of BACE inhibition, we also quantify 2 classical synaptic markers, synaptophysin and PSD95. And basically, we did not find any differences in the synaptic density in the treated case compared to the untreated case. The only significant finding was that we found synaptophysin positive structures around plaques, and they were less common in the treated case compared to the group of untreated cases. And this is compatible with the fact that we found less neuritic plaques in this case compared to the untreated cases. We also look at other markers as SNAP25, and we found similar results, so no apparent changes in synaptic morphology or density in the treated case compared to the untreated case. And because conventional immunohistochemistry has limited resolution, we apply a technique we have set out in our lab called array tomography microscopy, which is especially suited to image synapses. This technique requires a special fixation. You also need to ultra-thin sections, 70 nanometers, and special staining protocols to reconstruct the images using an in-house MATLAB algorithm. We cannot go into details of this technique, but there are recent publications from our group and others describing this technique. So in this case, we selected 5 cases for 5 untreated cases and the treated case for array tomography studies. And here we stain for synaptophysin and also for A-beta. And what we found is that this case had less synaptic associated A-beta compared to the untreated cases, as you can see here. So basically, to conclude, overall the conclusions is the neuropathological findings are overall mild. We found predominant diffuse and primitive amyloid plaques and extensive neurofibrillary tangle pathology. There were low levels of a subset of A-beta species stained by NAP61 compared to untreated cases. There was also low synaptic associated A-beta compared to untreated cases, and also low synaptophysin positive dystrophic terminals compared to untreated cases. The study has several limitations. The main one is this is a single case study, so it's difficult to know whether the effects that we see, the findings we see, are due to the drug or are part of the inherent variability in AD neuropathology. And also there was a 15-month washout period between the treatment and autopsy. And with this, I want to thank all the people in my group, especially Marta Carol and Sonia Kijisiristi, who participated in the study, and also the group from Hospital Clinic and the Brain Back in Barcelona, Raquel Sánchez Valle, Ellen Gelpi, and Laura Molina Porcel. Thank you very much.
Great. Our next speaker will be Julie Stone, who'll be talking about modeling and simulation to inform potential new strategies for BACE inhibition in AD.
Thank you for the opportunity to present. So my disclosures are evident here. I'm an employee of Merck. And what I want to do today is take some of the models that we developed from the verabecestat data and other data that's available and kind of turn them around in simulation mode to think about some of these alternate use scenarios that have been raised in this session and think about, well, what do we think? What's our best guess as to what would happen? So just to sort of frame this, obviously what we've been talking about is the potential that there might be a path forward for very low dose or low inhibition level BACE inhibition. So we have to think about what scenarios that currently aren't tried might we think that would be useful. And there's sort of two with that focused on for simulation purposes. One is, could we intervene very early in disease at a plaque load less than 50 centiloids, and would that be useful? The alternative is, we've seen the dramatic effects of the amyloid mAbs. A lot of discussion now, what happens after you take someone to amyloid negative? What should you do with that patient? So we decided to play with the scenario of once they were amyloid negative, what would happen if you put them on a BACE inhibitor? So again, what we do is we use the models as a way of integrating our knowledge, our understanding, to make a best guess as to what might happen if we did these alternate uses. And I focused on two things. One was sort of efficacy. What would happen to plaque over time in these settings? But I also, at the end, I want to circle back to, as we start thinking about a trial, we looked at what sort of sample size would we need to have confidence that these lower doses, this lower level of BACE inhibition, would actually not have the negative cognitive effects. So let me walk you through. There's two different models we're going to be using. The first one is really an amyloid plaque turnover model. I'm lucky in all the models we've presented, I'm going to talk about today, were already presented as posters on Sunday by colleagues in their current versions. So I'm going to give you very light details on the models, but I believe they're all available in the virtual space if you want to go back and look for more details. So the plaque turnover model uses the PET data to model how the amount of plaque or the PET signal changes over time. And this is really reflecting a growth phase. So I'm not talking about probability they nucleate and start Alzheimer's disease, but it's really once they've kind of got Alzheimer's disease, how does it grow over time, the plaque load? And we've fit this model to a full data set, which is verabecestat individual data, but also summary level data that we've gleaned from public space for all the amyloid mAbs that have made it to the clinic. And what you see in the little schematic on the lower left is we are using a simple turnover model. This is a common modeling approach where you have a zero order, a stable input rate, which would be what you would think of as monomer or oligomer adding onto plaque. And then you have a clearance rate, which would be the body's natural process of removal plaque. And that's a first order process. So as the amount of plaque increases, the rate at which that happens goes faster. So if you see the dotted red line here, that's a simulation of a typical curve. So early on, after you've initiated the disease, this would project that you have a very strong forward pressure for growth and a very steep growth curve that would, as you increase your plaque load, start to slow over time until a stable plateau is reached somewhere over 100 centiloids, somewhere in that zone. It's just very typical of the sort of plaque profiles we're seeing with natural progression. So we model the effect of BACE inhibition as inhibiting that input rate. And so that's just working in terms of how new material coming into growth. And you can see I've simulated different interventions starting at 85 centiloids, which is about 20 years after this whole growth period has started. And you can see with a BACE inhibitor, even at a pretty high dose, it's a pretty small effect because it takes time. Because although you shut off the input rate, it's still the natural over 6-year half-life to remove that. So over a 2-year trial, you do see meaningful reductions, but it's a slower process than we see with the mAbs. Because for the MABs, what we modeled that effect as is accelerating the clearance rate. So basically, by binding to the plaques, activating microglia, you have accelerated clearance. And pretty dramatically, for some of the most successful MABs, this is on the order of 15-fold increases in the rate of elimination, is what we estimate. And what you see in the simulated profiles is that can, over that 2-year process, as we've seen in the trials, dramatically reduce and bring the patients back to amyloid negative. So using this model then to simulate those 2 use scenarios that we're playing with and discussing among this group, what I first looked at, and the table shows that, is what is the dose of varabacestat one would need at different levels of starting centiloid to halt the growth at that point, so they wouldn't grow at all. And that has a really strong dose dependency that actually mirrors what I was talking about in terms of the natural curve. That early on, if you start at 10 or 20 centiloids, there's a really strong forward pressure towards growth of the plaque. And you'd need a fairly high dose, 27 or 12 milligrams as shown here in the table. And that's in the dose range where we saw the negative effects in the varabacestat trials. But if you wanted to halt it a little further in the process, when there's a little less forward pressure, you could do that with doses less than what have been studied clinically. And even at 50 centiloids, merely 2.9 milligrams would halt the growth. And I've shown in the table 2 columns. One is the percent inhibition based on the effect on PET, but I'm also showing from our CSF biomarkers the more traditional inhibition we see. And that ability to halt plaque growth at 50 centiloids could really occur around 35% inhibition by the traditional CSF biomarkers. So, last in the figure in the bottom, we show you what 35% inhibition would look like intervening at different stages. And what you would do is you would slow the growth and then you'd halt it at a lower level. I think the big open question is that clinically meaningful? I mean, I think instinctively slowing it, we'd think would probably slow progression of the disease. So that one, I think there's a sort of instinctive sense that could be useful. Whether halting at 50 centiloids would be useful, I think, is a completely open question. We've seen with people with full plaque load, you have to take them to amyloid negative. But if you're talking about someone early in disease, and a lot of the other pathologies and the cognitive effects don't really show up till you're above 50 centiloids. So it remains an open question, but at least this is what we would expect that intervention would look like. Let me show you the alternate use, and that is if we applied a low-dose BACE inhibition around that, after you had removal of the amyloid plaque down to amyloid negative using an amyloid MAB. And that's what's shown here in the figure. And it's really kind of the same story, that what you would do is slow the regrowth, and you'd halt it at a lower level. The doses need to hold someone amyloid negative would still be in that range where we saw the negative cognitive effects. But again, you come back to this question, would a slower regrowth and halting at a lower level be clinically useful? And I think we can't really answer that without more work, but it's intriguing. So let me switch now to the second goal, which is really to think about sample size. And for this, we're going to use a different sort of model. This is our varabacestat disease progression model, which was also presented, the most recent version of it was presented this Sunday by my colleague, Hub Klein. And so you can find it virtually. But here what we're doing is we're looking at the cognition data over time, and we're modeling it as a continuous process, what's happening with disease progression and cognition. And with this sort of model, what you do is you fit parameters that describe aspects of the progression. So the underlying natural rate of decline, the placebo response we'd expect. And then we tested for drug effects of an early offsetting effect, and drug effects on altered decline. With varabacestat, you see the typical profiles here in the figure. And what we saw was that there was a signal in both our mild-moderate trial and our prodromal trial for that early offsetting effect that was evident by week 13. But then afterwards, they decline in parallel. And we didn't see evidence that there was an alteration in the rate of progression. So clearly not a positive risk-benefit for these trials, but we don't know what the situation would be in some of these alternate uses. I would point out it's a relatively modest deficit compared to the relative decline, but so let me switch now to my last data slide, which is really that sample size. So we did clinical trial simulation. So we used this model to simulate trial data, and we had some of our replicates, we had that offsetting effect, some of them didn't, and we had different sample sizes. Then we used the model to test whether we could correctly identify when that offsetting effect was present. And what the results showed was, for really small arms, like 15 or 25, there's a huge false negative problem of identifying that negative cognition effect when it wouldn't be present. But if you get up to around 50 and you use a p-value 0.01, you actually get to a place where 95% of the time you make a correct conclusion from the trial. So it's not an unreasonable size where we could get a sense of whether these lower doses would also have a negative cognition effect or not. So in conclusion, just to wrap up, we think these very low doses BACE inhibition would slow the growth and halt the plaque at a lower level. This is all based on intervening after they've nucleated, started disease. I think it still remains an open question whether that's therapeutically valuable, but something I think as we explore how to manage patients, it's worth understanding further and getting more data. And a sample size of 50 would be sufficient for us to test whether there was a negative cognition effect in this new scenario. I do recognize here my many colleagues who've helped contributed to this work. Thank you.
Terrific. And last but possibly least, no, definitely not least, is my colleague, Dr. Paul Azen, who will be talking about how BACE inhibitors will be studied in clinical trials.
Thank you for that kind introduction, Risa. My disclosures first. So what I'm going to talk about is the clinical perspective and clinical trial perspective on BACE inhibition. I think there are a number of unanswered questions, and my conclusion will be these questions really call out for testing, and I hope that we can bring BACE inhibitors back into clinical trials. Efficacy questions include whether there will be an additive benefit to BACE inhibition on top of amyloid-removing immunotherapy. After all, a BACE inhibitor will reduce monomeric, intracellular, and extracellular, and oligomeric A-beta beyond what we would see with immunotherapy, and I think it's quite plausible that there would be an additive or synergistic effective combination therapy. We've talked about the need to maintain benefits from amyloid removal, which currently requires intravenous therapy, and a BACE inhibitor might be an approach to maintaining a benefit of amyloid removal. And I think particularly important, monotherapy with a BACE inhibitor makes strong sense as a potential primary prevention approach to AD. There clearly is cognitive dysfunction or synaptic toxicity with BACE inhibitors, but these effects in general seem to be dose-related, they seem to be reversible, and we know how to monitor for them. I believe we can design safe trials of BACE inhibitor therapy at lower levels of inhibition, lower than 50%. I believe we can do this now. Since Risa is sitting next to me, I start with this review of the AHEAD program, which was designed by Risa and Keith Johnson and myself years ago. And our goal in the AHEAD program was to develop therapy for preclinical, pre-symptomatic Alzheimer's disease, and even pre-preclinical Alzheimer's with very low levels of amyloid accumulation. And our initial plan was for the A45 arm of AHEAD, we would remove amyloid with an amyloid-reducing antibody treated in conjunction with a BACE inhibitor. And after a period of time, 18 or 24 months, we would stop the antibody and continue the BACE inhibitor. And I think the rationale for that approach continues today. The A3 arm of AHEAD was to be a BACE inhibitor alone. And the preclinical arm, these are individuals, again, cognitively and clinically normal, but with amyloid levels of 20 to 40 centiloids. And at that level, it seemed plausible then, and still plausible, that a BACE inhibitor alone might be sufficient to slow biomarker progression and eventually have a clinically meaningful effect. Now, this plan for AHEAD was changed as BACE inhibitors were discontinued from development. And as we move forward with AHEAD, we have substituted a lower level of amyloid-reducing antibody therapy for the BACE inhibitor in both the A45 phase 3 arm in preclinical AD and in the A3 arm for preclinical AD. Now, it's clear that there's cognitive toxicity of BACE inhibition. But we know how to measure this. We see this in all of the trials that you've heard about, and we can use stage of disease appropriate cognitive measures to monitor our trials for cognitive toxicity. So in the preclinical space, the PAC and the R bands are sensitive to cognitive impairment from BACE inhibitors. And in the early stage and in MCI, the 8S-COG13 and the R bands are clearly able to demonstrate cognitive toxicity from BACE inhibitors. These can be monitored. The results can be reviewed by external data safety monitoring boards and can help us assure safety as we hopefully move forward with low-dose BACE inhibition studies. Now, just to reprise a little bit what Elise started with, the cognitive toxicity that we see with BACE inhibitors is of rapid onset, and it is non-progressive. And in fact, in the Vera-Basistat study that I'm showing you here, with time tended to narrow. So in this slide, the curves going up are showing cognitive impairment, and placebo, shown in black, starts off better, but the curves become superimposed towards the end of the trial. It is a non-progressive toxicity. We would say the same looking at the Lana-Basistat studies, and I know these are kind of small, but again, the cognitive toxicity is non-progressive. I would also say that what we've seen in some of these trials is that it's not toxicity across all cognitive domains. There tends to be no toxicity or less toxicity in measures of language. And it's an interesting finding that requires more investigation. But in all of these studies, the cognitive impairment is limited and non-progressive. And as Elise showed at the outset, in the Atabasistat preclinical AD trial, we brought people back after discontinuation of the BACE inhibitor and found that the cognitive toxicity reversed with stopping the drug. So again, limited, non-progressive, reversible, and readily monitored. So I think that the cognitive toxicity is manageable. And I believe that we can safely proceed with lower dose BACE inhibitor trials with the understanding that we have today. Now, what I think may be the most important theoretical benefit of BACE inhibitors is in the primary prevention of disease. So our field has changed dramatically. We now have plasma measures that are highly accurate indicators of dysregulation of amyloid processing. They show abnormalities prior to the onset of any fibrillar deposits. They allow us to identify individuals before they have preclinical or presymptomatic AD with an amyloid load. They can indicate people who will eventually head towards amyloid accumulation. In this population, in my view, amyloid-reducing immunotherapy would not be likely be helpful because there's no fibrillar deposit to attack. I think the appropriate therapeutic approach would be to inhibit generation of the peptide with a BACE inhibitor or perhaps a gamma secretase modulator. These sensitive measures not only would allow us to select people prior to the development of amyloid accumulation shown by PET scans, we would be able to use these plasma measures to follow the beneficial effects of a BACE inhibitor on the abnormalities we use to select individuals. So I think that a low or moderate dose BACE inhibitor is an approach to primary prevention, that is before any amyloid accumulation occurs, primary prevention of Alzheimer's disease. And I hope we can move forward and explore that theoretical approach. I will stop there.
Well, I want to thank our speakers. This was a great session. Now we open it up for the panel discussion, and I invite our audience to ask questions.
Do you want to start with one online as people
Sure.
are coming up? Because there are several good questions. So the first is about seizure 6 knockout mice, and does this show an effect on synaptic plasticity or synaptic measures?
Yes, actually in seizure 6 knockouts we have reduced spinal plasticity, similar like the effect of the BACE inhibitor in wild-type mice.
And one more related to that in terms of, actually someone's asking about whether there was, the BSI could be due to a rebound effect of either missing a dose or in between doses suddenly increases in the A-beta acutely, in A-beta production. You might answer that one.
I was going to go on to our audience. Please state your name and your institution.
Melbourne. I have a question for Stefan. I didn't see SAPP beta on your volcano plots. So the question is very simple. What are the prospects for measuring the primary substrate in blood as opposed to CSF and getting a handle on dose efficacy relationships?
We are in the process of analyzing plasma as well. We need to keep in mind that a number of the BACE1 substrates are mostly neuronally expressed and would therefore be found predominantly in the brain. We know that the A-beta concentration in the brain is much higher than what we see in the blood, so we have to be prepared that a number of those BACE1 substrates will have an extremely low concentration in the plasma, but I'm pretty confident that we will find at least a few BACE1 substrates that can easily be measured in the plasma and may serve as therapy response markers.
So I have a question for Stefan. So you showed at the 5 milligram dose of, I forgot which BACE inhibitor that was, but it probably was, in your view, there was less evidence for cognitive worsening with that dose. What was the A-beta lowering of that particular dose?
That A-beta lowering was also less compared to the other drugs. We had it in the volcano plot. I would need to look it up again. It was in the range of 50% or less. So clearly it was not as high up as for the other drugs. I think it was below the 50% dose.
Yeah, that was adabacistat, yeah, it was
This was
targeted.
adabacistat, exactly.
Yeah.
Okay, so it does support the idea of about 50% lowering
Exactly.
would avoid the cognitive worsening, but also reduce A beta by about 50%, which should, at least in the mouse studies, should be preventative or at least slow down growth.
Exactly. And perhaps I add one more point to you, the point that you raised, Colin. When we do proteomic studies, we do the tryptic digest of all the proteins in the CSF and then analyze them. So we detect peptides per proteins that we use for the quantification. If we do the tryptic digest, we can no longer distinguish between SAPP alpha, SAPP beta. So that's parameters that you would need to measure by ELISA, just like the A beta as well. And that's the reason why typically the A beta reduction is even stronger than for some of the other substrates. Because if one of the substrates is cleaved by an alpha secretase and by BACE1, then by mass spec we can only see the total changes in the cleaved and released fragment. If you specifically want to look for only the base-dependent cleavage product, we would need to generate a cleavage site-specific ELISA, and then I'm sure that we would also see the same strong reduction.
Randy.
Hi, Ralph Nixon, alias Randy Nixon, and I'm from NYU and Nathan Klein Institute, and I'm really happy to hear that we may be revisiting the partial inhibition of BACE because it fits best with the preclinical data that show that you can rescue a lot of the phenotype with a partial inhibition. Paul mentioned some of the additional benefits over and above the amyloid benefits that might be the entry of the drug into cells and attacking some of the pathology there. One of the things that has puzzled me over several decades is the fact that we never talk about beta CTF, the direct product of BACE, as a pathogenic molecule that would be targeted in this therapy and would be a win-win if the reversal of pathology mediated by